Good afternoon, everybody. Welcome. This is our July webinar. We've got an incredible cast for you today. We're going to be talking about SDOH efforts and how you can use your SDOH efforts and lead to real results. A great program for you today. We have several hundred people joining us today, so we're going to give them just a few minutes to log on here. Jump in the chat room and tell us where you're logging in from around the country. If you're on vacation, tell us where you're vacationing, but we want to know what states we have represented here. Sam, what state are you in today?
I'm in Maryland.
Ah, great. Wonderful. East Coast. Andrea, where are you logging in from?
I'm also logging in from the East Coast. I'm in Western Massachusetts.
Okay, all right. Massachusetts is probably cooler up there. Stacy, where are you logging in from?
Chicago, Illinois.
Oh, great. And Melissa?
I'm here from DC.
Okay, so do we have any other Illinois folks, Massachusetts folks? Tell us if you're out there. Colorado, hope you're having some good weather. North Carolina, great to see you. Wonderful. We've got a good group here today. We definitely have the DC contingency here with Sam and Melissa and myself. So great to see everybody. Utah, welcome. Ohio, welcome. Great to see you today. New York City, hi. Oregon. Okay, we've got somebody from Boston, Tim. So you've got some company there. Brianna, welcome from Kentucky. We've got the Midwest here. West Coast, Ryan from Oregon. Thanks for coming today. Great to see you. Southwest, we've got New Mexico, we've got Utah, Texas. Wow, I've heard it's hot down there. So welcome, Texas. Great to see you today. And San Diego, beautiful San Diego, Washington. Welcome. Welcome, Tina from Connecticut. Hi, Amanda. Welcome, everybody. Great to have you here today. We've got an incredible program, a really great casting group here today. I mean, a very impressive lineup of speakers. So I'm just delighted to have them here today. Thanks all of you for joining us. We've got a really big audience today, so I want to give everybody a few moments to log on. Welcome. This is Executives for Health Innovation, ensuring your SDOH efforts lead to real results. Welcome. Wonderful. Now, more Kentuckians. Welcome, Arizona. Well, while you guys are logging in, I've got just a few introductory slides that I'm going to go through. So let me get started on that. Continue to tell us where you're logging in from around the country. We'd love to hear from you. And we want to keep this chat box real active today. I've got my partner in crime here, Emma. Emma Lloyd, say hello, Emma.
Hello, I'm here.
Emma is here. So Emma's going to be manning the chat room today. So please reach out if you've got questions, comments as the speakers are talking. We want to hear what you think, what your experiences are around the country. That just adds to the conversation. So thank you for joining us and for participating today. We want as much active conversation and discussion as possible in that chat box. So welcome. And wonderful Bianca, who's going to be helping with the slides today. Thanks, Bianca. All right, let's go to the next slide. Great. So who are we? Executives for Health Innovation. Who are you guys? Well, we changed our name from eHealth Initiative to Executives for Health Innovation early this year. So hopefully you got that note. But we are still EHI. So welcome. This is an EHI event this afternoon. EHI is a catalyst for healthcare transformation, and what we do is convene diverse leaders like all of you today joining us to talk about opportunities for collaborative innovation. And that's what we'll be doing today. Next slide. And we've got a couple of great focus areas: modernizing public health, health equity, virtual care, and privacy and security. And we do education, research, and advocacy around these areas. And of course, social determinants of health falls into a couple of these different areas. So we'll be touching on a few of these today as we go through our discussion. Next slide. And if you're not involved with our organization today and you would like to be, this is just a smattering of some of the executives that we work with that are on our leadership council. And you can see a number of really great influential organizations here. If you don't see the logo of your company there and you would like to join us, go ahead and reach out to myself or Emma through the chat box today. We would love to get in touch with you and share information with you on how you can get involved with our programs. So please, next slide. And I want to make sure everybody is aware of this great new report that we released about 2 weeks ago on tackling cybersecurity threats without sacrificing usability. A really great brief, easy to read. We'd love for you to download it. It's free. Share it with your colleagues, other professional friends. It's great, easy reading, and it's got really good insights and solutions from different leaders around the country. Very practical solutions. And if you're looking for any other resources, be sure to check out the EHI Executive Resource Center, which is online. You can go to ehidc.org, and we'd love for you to download or upload any resources, reports, charts, anything. It is really a knowledge forum. So if you have things you would like to share or you would like to look for, feel free to go in there. Hundreds and hundreds of articles and reports available. Next slide. And what's next? So we will have a few slides today. So if you're interested in the slides from today's webinar, or you know somebody who missed the program today and would like to see the program, or you think, wow, I wish the other folks in my office had seen this, feel free. We're going to send this out later today to everybody who registered. You're going to get an email with direct links to the video and also to the slide. So you will get that later on. All right, and a big thank you to our sponsor today, LexisNexis, who's doing, you'll see, some pretty amazing things in SDOH. But we do want to thank them. We are a very small nonprofit, and without the gracious support of organizations like LexisNexis, we could not bring this type of program to you. So we're really grateful to LexisNexis. So Andrea, thank you. Next slide. All right, so we've got a pretty good lineup today. We're actually going to start with Samantha Merklier, who is the Senior Policy Advisor, from HHS ONC, the Office of the National Coordinator. We're going to start with Sam. After Sam, we're going to hear from Andrea Green, who's the Director of Healthcare Strategy at LexisNexis Risk Solutions. Then we'll hear from Stacy Ignafo, who's the Executive Director for Community Health Innovations at Sinai Urban Health Institute. She's got a great case study on how she's doing this in her organization. I think you're going to be really impressed with this. And then last but not least, we're going to hear from Melissa Quick, who's the co-chair of the Aligning for Health group, who's going to talk about some of the legislation and policy out there related to SDOH and give us a little bit of an overview in terms of what she thinks is happening there. So a really great lineup today. Welcome to all of you. We're going to jump right in because we've got such a great lineup. I do want to let folks know, if you have questions as we are going through, please feel free to put them in the Q&A box. If you would like for us to formally address them, you can see that Q&A box below. If you've got just kind of comments that you want to share, go ahead and put those in the chat box as well. But we're going to start off with Sam Meckler from ONC. And welcome, Sam. Great to have you here today.
Thanks so much for having me. It's really such a pleasure and honor, and really excited to join you on this timely conversation and to contribute with the other panelists today. So I'm Sam Meckler. I'm a Senior Policy Advisor at ONC, and I am delighted to take the next 10 minutes to focus on, I was asked to focus on some of these components with you. So how does ONC see its role in advancing community SDOH programs? What are some of the policy developments to be on the lookout for? The types of resources that at ONC we provide to communities, and finally, some thoughts on ethical considerations that are being raised in this space. So who are we at ONC, and how are we working to advance the use and interoperability of SDOH to support communities and person-centered health? We are the principal federal coordinating entity advancing health IT for the nation. Our mission is to improve the health and well-being of individuals and communities through the use of technology and health information that is accessible when and where it matters most. We recognize health IT alone cannot address all the societal and institutional factors that drive inequities in the US today. Inequities in the conditions in which people live, learn, work, play, and age are driven in large part due to systemic root causes of poverty and racism. Interoperability, the capture, sharing, exchange, and use of health data, not just clinical data, but broader data, including social determinants of health, is critical for identifying and addressing disparities and for enabling holistic, integrated, person-centered care across clinical and community-based settings. And at ONC, we are closely focused on health equity in all of our policies and projects in alignment with the priorities of the administration. So in terms of our work to advance the use and interoperability of SDOH data, we really focus on 4 key areas. This includes standards and data, infrastructure, policy, and implementation. So as examples, part of this entails guiding the development, dissemination, and adoption of health standards, informing policy development to overcome interoperability challenges, supporting states and local governments in partnership with our federal friends as they invest in infrastructure for SDOH data, and driving innovation in care delivery by using tools and standards that can integrate this data into workflows. So what are some of the specific policy developments to be on the lookout for? So when we think of key policy developments, I really think of policy levers in this space. Having awareness of levers to advance SDOH interoperability is really critical to support your work. So what do we mean by levers? Federal policy and program levers include, but are not limited to, things like funding, guidelines, recommendations, regulations, strategic partnerships, training and technical assistance, research and evaluation, and so forth. So as you can imagine, there are many HHS policy levers that can be utilized to help promote SDOH data use and interoperability. One recent example to spotlight briefly is CMS finalized that all special needs plans complete health risk assessments of enrollees that include specific standardized questions on housing stability, food security, and access to transportation. So in this space at ONC, we work with federal and non-federal partners to identify, develop, and advance levers for health IT, SDOH interoperability, and data use, including those aligned with the goals of the Federal Health IT Strategic Plan, the Department of Health and Human Services Social Determinant of Health Action Plan, and broadly with the administration. So just a brief note on the Department's Social Determinant of Health Action Plan. This was released in April. It's entitled Addressing Social Determinants of Health to Advance Health Equity. It consists of 3 goals, and the first focuses on building a robust and interconnected data infrastructure to support care coordination and evidence-based policymaking. As next steps, there'll be a further focus on standards to enhance collection of SDOH data and facilitate referrals between health and human services, and this work is underway. Another key policy development to spotlight for those who may not be familiar is referred to as the United States Core Data for Interoperability, or USCDI. So there's a slide we can pull up here. There's a lot on this slide. I'm just going to talk about it at a high level. So this is a standardized set of health data classes and constituent data elements for nationwide interoperable health information exchange. It's really a key building block. It's a portfolio of standards and also a policy construct. It comprises a core set of data needed to support patient care and facilitate patient access using health IT, and establishes a consistent baseline of data for other use cases. It expands over time through a predictable, transparent, and collaborative public process. The second version, this is version 3, but the second version, and which is also included on this slide, included 4 social determinants of health data elements, as well as sexual orientation and gender identity data elements. Data elements related to health equity, such as race, ethnicity, and language, were included in the first version of the USCDI. There's a standards bulletin. There are lots of links that I've provided that will help you take a deeper dive that explains the USCDI construct and the versioning process as well. So I think a key thing to spotlight is that for communities and settings without electronic health records, aligning with the USCDI provides an opportunity for greater integration with healthcare and the use of non-proprietary open data standards that could be supported through lightweight internet-based ways to connect and integrate with other systems. So a key opportunity really is to align with this USCDI. Okay, we can remove the slide. Thank you for bringing it up. So what are some of the key policy development opportunities to think about looking ahead? And one thing to spotlight is a focus on incorporating standards and social determinant of health standards and the opportunity it presents to do so as part of federal programs. So you'll note there's a CMS, State Medicaid Director letter that specifically encourages Medicaid programs to adopt and use gravity standards. This is a national collaborative consensus-based project that advances standards in this space. And there are also opportunities to advance the use of health IT-enabled tools and coded screening assessment instruments, as well as piloting standards in this space as well. So finally, also I was asked to speak a little bit about the types of resources that we at ONC can provide to communities that need help. So we do have funding projects such as LEAP and STAR HIE. We also support the Gravity Project, and I think we'll talk a little bit more about this perhaps as when we get to Q&A. But one thing I want to spotlight is our Social Determinant of Health Information Exchange Learning Forum and the foundational elements. So let's pull up that second slide. So this really gets at the how of electronic SDOH information exchange. There we go. Thank you. So based on engagement with technical expert panels over the course of several months, we developed this framework of interrelated foundational elements. It's shown in the circles here to inform and advance SDOH information exchange initiatives. These elements, it's not a one-size-fits-all approach, but really a conceptual framework to guide the planning, design, implementation, and evaluation process of electronic SDOH information exchange initiatives. So technology is not the only consideration in these efforts. The solutions are based in only one technological platform, or without the use of these data to facilitate interoperability, run the risk of creating additional silos. So the work here really relates, as it relates to information exchange, again, not just about the technology, but really about working across all these foundational elements. And you'll see that governance cuts across all these concentric circles. So after developing this framework with foundational elements, we recognize the value in pushing this out to support communities. We created a national resource to support social determinants of health information exchange through a national learning forum. It brings together a wide range of stakeholders and really focuses on sharing lessons learned, promising practices, challenges related to exchanging this data through monthly webinars. And all of this is recorded, it's archived, it's available online. And the focus varied on priority topics that you see here aligned with the foundational elements. And part of the approach really was to identify exemplars doing work in this space as well. So all of that, there'll be a link provided. And again, it's accessible and recorded for your deeper dive. So last, I was asked to speak about some of the ethical considerations that are being raised and what we're hearing. So broadly, when used properly to improve individual outcomes and equity, the incorporation of this SDOH data can promote health equity and improve the care of underserved communities. However, the misuse or bias in data, including that of SDOH data, can further exacerbate health disparities. Also, from an access perspective, less data may be available for individuals with limited access to care. The inconsistency in this data has the potential to exacerbate inequities due to reduced representation of populations with less access to care. So other factors clearly could contribute to reduced representation beyond access. And finally, from a screening perspective, we often hear stakeholders raise concerns with SDOH screening if a social needs identified that may not be addressed by existing community capacity. Care teams may be concerned that they may not be able to address that social health-related social need. And also, but what we see even back in early literature is that there was recognized value in helping to identify unmet community needs and to support advocacy, and that providers that were initially concerned with some of the burden indicated feeling that patients ultimately received more holistic care, improved care quality, and that their workloads were lessened. So last, in terms of bias and algorithms, ONC is examining various approaches to ensure that users have the ability to know how to apply algorithms in the right way at the right time and in the right situation. So stay tuned. Thanks so much for your time. And with that, I will turn it over to Jen.
Great. Thank you so much, Samantha. And we do have a bunch of links that Samantha mentioned in the chat box here. And then Emma's also going to send them out tomorrow with a link to the slides and recording. I know a couple of you were saying you wanted to go back and cover. We will, so you will have that information to look at. I'm really excited now to introduce Andrea Green with LexisNexis, who's actually going to walk us through a maturity model, which is pretty fascinating stuff, and I think lead us into some great conversation. Andrea.
Hi, everybody. Thanks so much for having me. So yeah, I'm going to talk a little bit more about this really wordy slide here. So LexisNexis Risk Solutions developed this organizational maturity model as part of our advisory services offerings because, it can really offer a way to help companies evaluate where they stand in terms of their SDOH initiatives or programming and, where they really want to go. So you can use this as a visual guide or a reminder to see, what level you're at for your current state, and then even think about where, you might be wanting to head. So really test yourself, what is my organization accomplishing? What should be my next step moving forward? Those kinds of things. So organizations really, I think, are striving to be industry leaders, that last kind of purple column, in order to have the biggest impact in influencing, health equity for all. You'll notice the domains, they include data as the foundation, right? So knowing your patient population or your target population is really key, and then scaling up and expanding out from there. We've been able to work with companies both on the for-profit side and the nonprofit side to segment their patient populations. They've been able to identify common barriers or hotspots, related to things like economic stability, housing instability, or even transportation difficulties. And then they partner with community-based organizations to help remove some of those barriers to meet the social services need, impact that health behavior, and then ultimately improve the health outcome. Our data has also been used in research efforts as it relates to things like cancer and financial stress, as well as SDOH stressors affecting behavioral health and suicide risk. Our vast amounts of data, so we're a data vendor, of course, but it allows organizations with analytics capabilities and data science teams to build their own predictive models if they don't want to use our out-of-the-box models that we do provide. So they're able to, they're able to look at their population and allocate resources more efficiently across their population. So really focusing on that rising risk population instead of just the high risk population, right? So a common oversight, I think, is that high risk populations may actually be harder to move the needle versus the rising risk population. So you want to be able to catch people before they fall off that edge or that cliff, right? So you're intervening sooner, and you can actually make a bigger impact and see a larger return versus waiting until somebody is high risk to intervene, because changing health habits and behavioral habits can sometimes be a lot more difficult in that higher risk population. I think most organizations out there that have SDOH programs or efforts usually fall kind of within that second bar there within the proficient level, that orange bar. We've worked with organizations that have taken their SDOH data, they've evaluated it, analyzed it, and started targeting patient populations for their SDOH programming and interventions, but they might struggle with integrating it right there into their workflow or even workforce development. I think those are some of the common struggles that we've seen. So workflow integration seems to be a common sticking point. So mostly because organizational change can be challenging, right? And, like in the provider setting, for example, there's so much focus on quality measures and clinical documentation integrity and patient satisfaction scores, or even door-to-door times or length of stay. And it's difficult to cram something else in there without really being able to back up the reasoning behind it. So that's why focusing on health outcomes is important. You'll see that's right under the kind of the step down from workflow integration. And it's a necessary step to really integrate into standard work if you want to integrate SDOH into your standard workflows kind of across your organization. The other thing I want to say about workflow integration is sometimes workflows can kind of be broadly laid out as a just do it methodology, but no one has really taken the time to spell out who does what, when, how, and why, right? So integrating SDOH or information into workflows really falls into what I call the 5 rights of workflow integration. So I'm going to allude to some of my nursing background here. In nursing, we have the 5 rights of medication administration, right? So you have the right patient, the right med, the right dose, the right route, and the right time. And I see SDOH workflow integration very similarly. You have to have all 5 rights defined in order to be successful. So this means getting the right information in front of the right person at the right time, in the right way, and for the right reason. So there was a really great study that was done by the University of Alabama at Birmingham, and I can drop that link in the chat when we're done, where they noted patients experiencing homelessness were as much as 15 percentage points less likely to report unfavorable experiences at their primary care setting. And if the clinical staff made an effort to target or address their SDOH needs, and this was specifically for homelessness, right? And I think this is a really valuable example of how a secondary effect of addressing SDOH barriers can lead to a return or a benefit to a primary focus like patient satisfaction, right? You know, SDOH is a buzzword, and companies are paying attention, and the companies who are paying attention either need to start looking at SDOH barriers, maybe for financial reasons, or want to start addressing health equity because it's mission driven or mission focused, right? They're doing it for the right reason. The common denominator usually, though, between those two groups is that they're skipping steps along the way. So, for example, they may be focusing on, or they may not be focusing on workforce development and wanting to kind of skip straight into maybe research. And this can make it difficult to sustain integrated workflows because their staff might not fully understand the reasoning behind addressing these social barriers, right? So this can actually cause some irregularities in your SDOH interventions or your health equity efforts because everyone might be doing something a little bit differently, or they may not necessarily really understand the intent or the goal or the outcome of the program. So this is just an example of how a maturity model like this really builds upon itself, right? So if you're looking to have sustainable partnerships and even do research-based work on those higher levels to kind of fall more in that advanced level as an industry leader, you know, your frontline staff should be well versed in health equity, cultural competency, you know, diversity and inclusion. Otherwise, the foundation under that house is more fragile and may not be stable or even sustainable. So I'm also going to drop another resource in the chat after I'm done. It's the American Hospital Association, and they have a great tool called the Health Equity, Diversity and Inclusion Dashboard. And this helps break down data collection, community partnerships, cultural competency training, and it even includes some diversity and inclusion in leadership and governance. So this is a really great resource, and I will make sure to add that in there. Lastly, I think I'd like to address some potential implications for organizations that are slow to change or maybe slow to evolve their programs. So, you know, they're going to start seeing their competitors pass them. They're going to blow by them in the fast lane in terms of patient outcomes, cost savings that might be related to, you know, managing your patients with chronic conditions or even just attrition rates for members in health plans. Patients are consumers, right? And they can choose where to get care and what health plan they want to have. You know, they're going to choose the ones that are treating them like whole people and not just their diagnosis. Some examples of companies that are covering eligible healthy foods or groceries are Humana, United Healthcare, and even there are even companies that will partner with providers or healthcare organizations like hospital systems with nonprofits like a company called Fresh Connect in Boston, and they offer grocery cards with a prescription. So essentially prescribing food as medicine. So I think those are some really great examples of ways that patients as a consumer can kind of just look at the types of programs or the types of healthcare that they can receive and where they can go, and then decide based off of these additional interventions that we can provide related to health equity and social determinants of health. So I'm going to drop my links in the chat for you for the Alabama study and even Edible Boston, I'll throw in there. And I'm going to turn it back over to Jen.
Thank you so much, Andrea. We've got a lot of questions, and this is a great model for folks to take a look at. This is going to be available in the slides and the link that Emma sends out later today. I know there are a lot of questions about that, but let's hear now from somebody actually in the field doing this day to day. Stacy, tell us about what you're doing right now. Really some incredible work.
Thank you. Thanks so much. Hi, everybody. My name is Stacy Agnafo. I'm the Executive Director of Community Health Innovations for the Sinai Urban Health Institute. I'm going to focus my remarks on an example or a case study of sorts of our work focused on addressing social determinants of health among our patient population. I'll provide a bit of a context about who we are, our model, because I think it's important, and then what we are learning from our work as well as our future directions. By way of background, the Sinai Urban Health Institute, or SUHE as we call ourselves, we're the community engaged research arm of Sinai Chicago, which is Illinois' largest private safety net health system. The communities we serve are historically marginalized, overburdened, and under-resourced, challenged with a multitude of issues such as high rates of chronic disease, violence, structural racism, and a multitude of social challenges. SUHE's mission for over 20 years has been to really go outside of the hospital walls and to improve health equity among the populations we serve, really engaging the community every step of the way to really understand and provide context to the inequity data that our organization and others collect. But to also harness the community assets and really prioritize needs based on the input of the community. SUHE, as one of our focus areas, has been developing, implementing, evaluating, and scaling community health worker interventions for over 20 years in the areas of disease management, outreach and navigation for hard to reach populations, prevention, complex care, and addressing the health-related social needs among our patients and community members. This last model is what I'm going to highlight for you today as an example, one of many examples of our work. But for context, I want to define how we talk about community health workers, because I think it's important for what I'm going to outline for you today. We define community health workers as frontline, lay, public health, and an equity workforce who have an unusually close understanding of the communities and populations that the organization serves, whether it's through shared experiences, living in the same communities, demographics, or sharing in the same health condition. Community health workers build relationships of trust with patients and community members, meeting patients where they are at, not only in the hospital, not only in the clinics, but also in their homes and community areas. Community health workers are trained intensively in CHW core skills, which includes topics like cultural competency, motivational interviewing, conducting home visits, working with healthcare providers, navigating complex systems, and really so much more. They are also trained in specialty areas in which they are working, whether it's asthma or diabetes or social needs assessments, as well as the technology they're using in any given intervention area. Positive outcomes have been documented for CHW-led interventions including our own, and I'm happy to share some sources for that if that's of interest. But for the intervention I'm going to talk about, for the last few years, our CHWs have launched a CHW support program, which assesses and addresses the health-related social needs of our patients once being discharged from both the emergency department setting and the inpatient setting. Our community health workers primarily receive referrals from Sinai Social Work Department. Those patients who receive a referral from social work to a CHW are deemed to be at medium to high risk for readmission based on a screening tool used by our social work team. And this tool used by social work assesses things like self-reported health, the number of hospitalizations, number of ED visits over the last 6 months or a year, alcohol and drug use, whether that individual is houseless, and whether or not the patient feels safe at home, rather, among other. The more factors, the higher the risk on the screener. Thus, those with medium to high risk are referred to our community health workers. In addition, I think an important component of this program is that at the start of the pandemic, we also began receiving referrals for patients being discharged with COVID-19 who had a multitude of challenges that needed to be addressed. Once a referral is received from a community health worker, they contact the patient either by phone or in the hospital setting, screening the patient for social needs. So we really screen in the areas of housing and food insecurity, transportation, primary care or insurance needs, and utility assistance. Community health workers also assess the other health-related needs of the patients and ensures that the patients have what they need at home upon discharge. And importantly, that the patients understand their discharge instructions. They provide critical connections to social services and primary care, educate the patients, make follow-up appointments and referrals, provide social support, communicate with the clinical teams. And a crucial step is really following up with the patients to make sure services were accessed and followed up on, and if there are any additional needs that the patients have. Community health workers make social service referrals through a tool called NowPow, which connects health systems to social services in the area. They make appointments, and they also document in our EHR systems to keep the clinical teams aware of the needs of the patients and what's been done. Of the nearly 1,800 patients that have been referred to our community health workers since the inception of this particular program, we've been able to screen over 50% of them, and approximately 65% of those we've screened have at least one health-related social need. A great majority have more than one need. The most common needs that we've identified among our patients have been in the areas of food insecurity, behavioral health and emotional support needs, transportation challenges, and difficulty paying for the utilities. Importantly, we do track whether the patients have been connected to services, and over 82% of those patients with identified needs have been connected to the services that they need. We've also been able we've been seeing promising trends in the 30-day readmission rates among our patients as well. Those screened, some of the preliminary data we have shows that those screened by a community health worker had a 23% readmission rate, while those not screened by a CHW had about a 34% readmission rate. To further build upon this data, we are working with a data scientist at DePaul University to analyze this promising readmission data more and to really dig into this. The motivation behind this particular partnership is to conduct analyses and develop techniques to measure the positive impact of the CHW support program on health equity. We're specifically analyzing the program data to see if we can better recognize patients who are more likely to be readmitted, and in the process show that the patients who are screened are less likely to be readmitted. We're also working on things like analyzing our CHW's notes to discover emerging needs improving processes by discovering, really discussing the results and integrating feedback from the community health workers. While this particular analysis is ongoing, our preliminary data suggests that we can predict ED readmission rate with an accuracy of about 68%. And one of the features with the most predictive value for this is the amount of time patients spend with the community health worker. We're looking into screening duration or duration of patient contacts, total time spent, number of contacts. And in addition to further analyzing this particular data, we're also beginning to look at how CHWs can improve the patient experience, which we know is important to healthcare systems and the patients we serve. One important experience that our CHWs have had since the pandemic has really been a striking spike in behavioral health related needs across ages and race ethnicity. We're also seeing spikes in violence within the communities we serve. Some of my colleagues are currently working on studying this a bit more on the experiences of COVID-19, structural racism, and violence to better understand how these challenges are connected. We're also working on getting our community health workers more equipped to handle behavioral health needs, and have even developed a CHW specialization training in this area so that we can begin to help fill the needs of our communities and identify more ways that community health workers can help in this space. Overall, our entire SUHE model is really built around using data to spur action. And this is one way we are doing it, to really help identify those patients that need this high touch approach to managing their health and wellness so we can better target interventions for the patients that need it. We believe this program has really high potential for societal impact, and believe the program is really scalable and can have potential for replication in other areas. In addition, the community health workers is really one in which you can improve patient outcomes, meet the needs of the healthcare system while improving health equity, and really building a workforce that is from, for, by, and with the communities you are serving. So anyway, those are the conclusion of my remarks, and I'm going to turn it back. Thank you for letting me share some of our work.
Thank you so much. Melissa, let's head over to you. Tell us what the lawmakers and legislators are doing.
I will do my best. Hi, everyone. It's great to be here today. My name is Melissa Quick, and I am a co-chair of Aligning for Health, which is an advocacy organization focused on addressing the barriers and challenges that limit our ability to improve health outcomes and well-being for all. Just as quick background, Aligning for Health, we represent payers, providers, networks, and other vendors. We were founded about 5 years ago with the goal of engaging in federal advocacy to support and enhance the growing number of cross-sector initiatives seeking to address social determinants and to enhance health equity across the country. So with that all being said, I'm here today, as Jen mentioned, to talk a little bit about what Congress is doing and what they're focused on related to social determinants of health. Now, without making too many jokes about Congress and their ability to get things done, I'll do my best to share some of what they're focused on, some of the bills that are before Congress, and hopefully we'll make it across the finish line this year. And then happy to answer any questions that you guys might have around any or all of that. So first, I wanted to start by saying there is generally pretty broad support in Congress for addressing social determinants of health. I'm going to toss some numbers out at you, which will sound potentially very large or very small, depending on your perspective, but we've been tracking through Aligning for Health a number of social determinants of health bills, and I define that pretty broadly here, that have been introduced so far this Congress, so since January of last year. So there have been at least 160 bills focused on social determinants, including funding for cross-cutting programs to address food, housing, transportation, and to improve social determinants of health program coordination, as well as over 50 bills focused specifically on eliminating health disparities or advancing health equity, and over 75 bills focused on maternal and infant health. So I say this in that we all know that social determinants can be a very, very broad term. It can include many different types of interventions and obviously impacts on an individual's life or the community or so on and so forth. So when I think about social determinants legislation, I like to bucket it out in a couple different kind of big, broad buckets here. So one is funding and programs that are meant to address upstream social determinants of health. So think of these as bills that seek to fund kind of cross-sector nutrition or housing or transportation programs. These are the types of programs that really are trying to stem the tide kind of very upstream and address the core drivers of well-being for all. The second big category are funding and programs that seek to address more midstream social needs. Notice the difference in terminology there. So these bills seek to improve incentives for providers or for payers to screen for social needs, to make connections with social services organizations, to make or track referrals, to provide flexibility in healthcare programs, to pay for interventions that address social needs, to fund community health workers, given Stacey's comments and I think some of the questions that came in through the Q&A box. As well as doulas or other types of clinicians that do support healthcare workers and many other types of entities in providing care coordination and care management and addressing social needs for individuals across the country. The third bucket is focused on kind of data collection and research or analysis. So these bills seek to improve the collection or interoperability of race, ethnicity, language data, SOGI data, which is sexual orientation or gender identity information, as well as social determinants or social needs data. These bills also seek to fund research or analyses to identify disparities or to assess program effectiveness across the board. And then the fourth bucket of bills, which is kind of I don't want to call it a catch-all, but these would be appropriations bills. So annually, Congress goes through an appropriations process, where they provide funding for federal programs, which may include kind of funding for all of the above buckets of bills that I mentioned. So just to give some examples of bills that are before Congress that we are tracking kind of within each of those buckets. On the upstream social determinants of health bucket, these might be bills that fund kind of WIC programs or SNAP programs or fund housing subsidies or housing vouchers, or more specifically funding for programs like innovative cross-sector programs like the Healthcare for the Homeless Veterans Program or something along those lines. Midstream bills are bills that we as Aligning for Health tend to focus most of our attention and advocacy on. So these bills tend to have strong bipartisan support and tend to focus on ensuring that federal programs and services have the right incentives and or structures in place to encourage activities to address social needs or better coordinate the delivery of benefits and services funded by federal programs today. So some examples of bills that we are tracking, and I know I'm going to rattle off a bunch of different names, but these can all be found on our website, which I think Emma is going to pop into the chat in a minute, which is aligningforhealth.org. So the first is the Social Determinants of Health Data Analysis Act of 2021, which passed the House last December, but has not yet passed the Senate. So this would require the federal government to basically issue a report detailing all of HHS actions to address social determinants. So I think Sam mentioned earlier that back in April, HHS actually did release a report that detailed everything that they're doing across the board on social determinants and then laying out their priorities and goals and strategies moving forward. But this bill, if passed, would require HHS to, or would require a government auditor to kind of go beyond what HHS has already put out and also detail the ways in which they are incorporating kind of data analyses as part of their efforts. Another one that I wanted to flag is the Social Determinants Accelerator Act, which is a bipartisan, bicameral bill that would direct the Secretary of HHS to establish an interagency council on social determinants of health, and that would also make grants to states and local communities to develop cross-sector evidence-based social determinants of health accelerator plans. Now, I note this one in particular because this has been partially already passed into law through the appropriations process. So in 2021, there was $3 million made available to the CDC. And then in 2022, there was $8 million available to the CDC to make grants to states and local communities to develop social determinants accelerator plans. And the notice for funding opportunity just closed earlier this month on July 8th, and they'll be announcing the grantees, I think, in September. But Congress is currently in the process of formulating the funding for FY23 for that program and has requested $100 million. So if Congress were to appropriate that full amount, it would be a fantastic expansion of that program and hope to provide resources and capacity to states and local governments across the country to develop SDOH strategies. And I think the last bill that I wanted to flag in a very long list is a bill called the Leveraging Integrated Networks and Communities, or the LINK, to Address Social Needs Act. And this bill would provide funding to states to develop a regional or statewide social needs information sharing systems. So think of this as like the equivalent of an HIE or a community information exchange. So basically, it is funding to enable entities to be able to build up the infrastructure and the capacity to share data, to make referrals, to track outcomes between health and social services organizations. And then lastly, I wanted to just flag kind of as in thinking forward about some of the interest and activities within Congress and social determinants. I'd love to make everyone aware, if you're not already, of the bipartisan Congressional Social Determinants of Health Caucus. So this is a bipartisan convening of 30 plus lawmakers in the House that are all committed and excited about advancing social determinants of health policy. They began their work about a year ago and issued a request for information and are currently working their way through many different requests from many different organizations about how to prioritize their time and legislative capacity to advance important bipartisan social determinants bills. And then lastly, and then I will stop talking so we can get to Q&A, just wanted to flag on kind of the future outcomes here. I think that there is bipartisan support for a lot of this work. We have to always take this with a grain of salt, given that there are many, many priorities that are going through Congress. But I think every legislator understands the impacts that social determinants have within their district or within their home state. Many districts and home states have different priorities with respect to social determinants, whether it's housing or transportation or food deserts or so on and so forth. But everybody understands that this is not something that will take a silver bullet. It's something where we all need to come together and make sure that we are leveraging the collective expertise of everybody on this phone or on this Zoom to advance forward. So that I'll pause and we can go to Q&A. I'll turn it back to you, Jen.
Great, thank you so much. And I know we've got so many questions, we're not going to be able to get to everything, but if everybody can jump back on camera, I am going to ask speakers, panelists today, if they're willing to put their emails in the chat box in case you want to reach out to them individually. We will be sending out, again, all of these resources, a whole list of resources for you guys to get back to. Because I know we haven't had time to go through everything. Let me just jump right into some of these questions. I'm going to start actually with you, Andrea. You know, I wanted to talk a little bit today about kind of the completeness of the data that these communities are collecting and how can we increase the completeness. We had a great question though about the limitations of using this data. Maybe you could address that.
Yeah, absolutely. I think there were two questions kind of related to data privacy and data security, and they kind of fall they go together, right, hand in hand. So the data that we provide at LexisNexis it comes from a variety of both public and proprietary data sources, and our data is highly regulated. So when our customers go through the process of purchasing our data, we we have a very extensive credentialing process, and it's very thorough, so we can ensure that our customers do have permissible use and permissible purpose, right? We do understand that SDOH data is not HIPAA protected, though we do provide identified SDOH data to only customers who have, or for patients where customers have a direct care relationship for those. So that is one of the limitations, right? You can't just knock on our door and say, I want SDOH data for my neighbor. That doesn't happen, right? So you have to have a permissible purpose. And along those lines, it also kind of falls into how long you're able to keep the data, because it is regulated, and what you're able to use it for. LexisNexis really prides itself in kind of this unofficial, official model of using data for good. And I just wanted to reference again the collaboration that we did with EHI, the guiding principles for ethical use of SDOH data. We could probably drop that in the chat there as well. But in terms of completeness of the data, you know, I think that that's something that organizations definitely struggle with, right? Because you can use survey data, you can use American Community Survey data, which if you've ever looked into it, is not necessarily comprehensive, right? So they don't survey every single US adult, and some of the data values are then used to kind of impute and say, oh, you know, Melissa Quick looks a lot like Andrea Green, so I'm going to assign her those SDOH values based off of the answers that Andrea Green gave, right? So you can use other survey data that you are asking your patients directly. Sometimes there are a lot of barriers with that, right? There's cultural competency that's involved, right? So the way that the questions are asked, and you know, how patients, the level of comfort that a patient might have with the person that's asking the question, and then also just basic workflows, right? So do providers have the time to ask the questions that they need to ask, you know, while they're also addressing many, many, many other things during their patient visits. So I think that taking kind of a multi-pronged approach is going to be the most effective solution, right? So not just looking at survey data, but also looking at other data sources.
Great, thank you. Stacey, you have a ton of questions here about the details of your program, and that's one reason I'm gonna hope that you're willing to have people reach out to you. But one of the things I would love for you to address, because you're out there right now, is some of the ethical considerations and issues, and how you guys directly address this. And, you know, Brenda makes a great comment in the Q&A box that, you know, a lot of this is not protected by HIPAA.
Yeah, we've been back and forth about this for years, and working with our institutional review board and others about what we need to do. And essentially, you know, what we're doing has been within our health system to be deemed kind of usual care. We're helping with patient needs, we're identifying needs. We don't do anything without the consent of the patient. You know, are you okay if I, you know, share this information with organization X, Y, and Z, who can help you get the food you need? And so we've really, you know, our CHWs are trained to really make sure that the patient is comfortable with the, you know, the data we're collecting, talk to them about how we're using the data, but also, you know, are you okay if I refer you to this resource who will contact you to help you with the needs that you have? I know there have been some discussions around some of the technology that's used to electronically connect patients to, or health systems to, social care systems. So like when our CHW goes into NowPow and they can electronically submit a referral to a food bank, for example. I know there have been lots of conversations around, how do you consent? How does that patient consent to that referral being sent? And, you know, I know some of the referral sources are working that out, but we always gain verbal consent and make sure that the patients are okay with us sharing their information, limited information, with the resources we're gathering for them.
Great, thank you. Sam, it would be great if you could briefly address the gravity standards and to what extent they're actually being applied.
Thanks for the great question. So for those not familiar, Gravity is a national public collaborative, and they develop consensus-based standards to improve how SDOH data is shared and used, and they really focus on the terminology. But I think what's important to know is that anyone interested in this space has a seat in the table to participate in those national calls. ONC has been involved in that effort from the start with some of our other federal friends, and supporting the governance and some funding as well. But when I pulled up that busy slide on the US core data for interoperability and talked about SDOH assessment goals and interventions and problems and health concerns, that USCDI V2 really for SDOH reflected, I think, the hard work that came out of that Gravity project as well. And also, I do think, and just to call out again, back to policy levers, really looking at leveraging those standards, and you'll see a reference to the Gravity project standards in that state Medicaid directors letters as well. So I think there's a lot of national engagement in this space. There's federal engagement and support. There have been some great successes out of the Gravity project when you look at how it's impacting and informing the work at ONC. We're engaged in the effort, and we'd encourage everyone to, check it out if you're not familiar with it, and there are opportunities to engage in piloting those standards as well, because there's obviously many persistent SDOH terminology gaps that they're focused on addressing.
Great. And Melissa, question about funding. Do any of these bills have funding in them?
Yes. I think all of the bills that I mentioned, well, I think I mentioned 3 bills. 2 of the 3 bills do include funding. So the Social Determinant Networks bill, the Link to Address Social Needs Act, would provide, I think it was $150 million to states. The Social Determinants Accelerator Act, the House and Senate versions differ, but and there are a couple different iterations, but it would provide several $1 million to states to do this work. And the CDC, of course, has already begun some of this work through the appropriations process. So there is $8 million available this year for said grants. And then I think beyond the bills that I mentioned, there is a lot of interest in building capacity and funding programs. I know that there were questions in the Q&A around kind of housing programs and nutrition programs and community health workers, and how do we fund all of this work that folks are really trying to build. I think that there is a lot of interest, and the question is just whether or not Congress can kind of get it over the finish line and move it over to smart folks like Sam to go implement.
Great. And we are going to have to wrap it up pretty quickly, but I want to just do a really quick round robin. So everybody's going to get a chance to just give us one quick piece of advice that you want to leave our participants with today in terms of moving forward. I mean, if you guys know a lot, you're the experts in this area. So what's the one piece of advice you would provide to people? And Andrea, why don't we start with you?
All right, so my piece of advice is this is a marathon, it is not a sprint. So baby steps, every step forward is a step forward. Start from the beginning and work your way up.
Excellent. And Stacy?
Mine would be to really consider this novel workforce to help supplement some of the other licensed professionals that you have within your healthcare system to really meet the health equity needs of the communities.
Great. Sam?
So I think mine is twofold. I think first, make sure you have communities seated at the table and that you have a broad tent of decision makers, and also to leverage non-proprietary open data standards. Even if you're not a health IT person, if you care about health outcome improvement, data standards and content and information is applicable, relevant, and valuable to your work.
Great. And last but not least, Melissa.
Sure. I think the number one thing that I would recommend is two things. One is build partnerships across sectors. So much of this work is being done in different places, and it's really hard to kind of reinvent the wheel for every individual person. And so much of this can be done if we just kind of pull our heads together. And obviously that is really tough and gets to all of the challenges that I think the 3 other speakers spoke to. But I think that would be number one. And number 2 is really reach out to, your state, local, federal governments and programs that are trying to figure out and navigate for this for you through this. Because I think they're also trying to figure out what are the additional barriers and challenges that need to be eliminated and how best to do that. And I think concrete examples from folks that are doing this work day to day is most impactful.
Great program today. Thank you, ladies. Our fantastic panel. Fantastic. Thank you all for joining us today. Look for an email from Emma tomorrow with all the information. If you have comments, put them in the chat box. We want to know what you thought of the program today. We're happy to do another one. So let us know what you think of the program. Thank you, Sam, Melissa, Andrea, Stacy. You were all wonderful. And stay tuned for more. Have a great day, everybody.
Thank you.
Thank you.